Good evening, one and all present here. I'm Suchira from Science Integra, and I welcome you all for the 9th webinar of Maha Smiles Cleft Care for Every Child. I would like to introduce you all to Miss Renu Mehta, who is the Area Director of Smile Train India. Over to you, ma'am.
Thank you, Suchira. Good evening, everyone, and a warm welcome to who all are attending this webinar series today. We have been having this as the 9th webinar in series, so you all must be knowing Smile Train. Smile Train is the world's largest cleft charity, and we have been working in India through a network of our partner hospitals since year 2000. Over the last 24 plus years, we have provided over 7 lakh free surgeries to children born with cleft. And Smile Train has been in collaboration with Foxy since 2019. Now, what is Maha Smile? Maha Smile is our flagship program because Bajaj is one of our very big supporters. And with them, we have launched this program where we are concentrating on the state of Maharashtra to make it cleft free. So for making it cleft free, a lot of awareness is required, and our effort with AMOGs, we are taking this cause forward hand in hand. So thank you, Foxy, thank you, AMOGs, for joining in this cause with us. And I would like to introduce Dr. Rashmi Kahar, who is the chairperson for AMOGs, and she's a very well-known professional in this field. So, ma'am, over to you to take this webinar today forward.
Thank you so much, Renu Madam. A very good evening to all of you. This is our 9th webinar of Smile Train. Smile Train. This is a webinar where we are trying to spread smiles through awareness about cleft lip and palate. We are especially thankful to our mentors, AMOG's President, Dr. Kiran Kurtakoti sir, and Secretary, Dr. Bipin Pandit sir, for their encouragement and support. Me and my co-conveners, Dr. Sujit Ponkar and Dr. Jaya Kore Tulaskar. We have with us today our State Coordinator of AMOGs, Dr. Girish Mane sir, as our guest of honor, and eminent speaker, Zonal Coordinator of AMOGs, Dr. Mangesh Narwadkar, and Dr. Bhargav Madam. So, Suchira always asks me which districts you are targeting through this webinar. So the districts we are targeting through today's webinars are Beed, Jalna, Sambhajinagar, Latur, Parbhani, Nanded, Usmanabad, and Udgir. So I'm immensely thankful to Maha Smiles, and I would like to request Dr. Bipin Pandit sir, who is our Secretary of AMOGs, to kindly bless us on this occasion.
Can you hear me?
Yes, sir. So please proceed.
Thank you very much for inviting me for this excellent seminar on Smile Train. And I must congratulate and appreciate the efforts of AMOGs, and Science Integra for reaching out to these children, where we try to diagnose them accurately and treat them. It's totally correctable deformity, which can be corrected easily, and these children will have a almost normal face. So thank you very much, and I'm sure you will all enjoy. And it thanks Rashmi and Dr. Ponkar and all the other conveners and Dr. Jaya for inviting me. Thank you very much. All the best.
Thank you very much, sir. Thank you for the constant encouragement and support. I would like to introduce our guest of honor, Dr. Girish Mane sir, to the house. As we all know, he has been the past chairperson of Adolescent Health Committee, Foxy 2019-22, with the Best Committee Award for his committee. He also has been past chairperson of Adolescent Gynecological Committee of AMOGs. He had been past president of Yamatmal Obijawai Society, and at present, he is vice president ISOPOP Vidarbha. With many awards to his credit, today we are blessed to have Dr. Girish Mane sir as our guest of honor, and we would like to request him to kindly address the house.
Thank you very much, Rashmi, for the generous introduction. And special thanks to you for inviting me for this program. To be very honest, I was not knowing this move, and I must congratulate and thank Science Integra for taking this very sensitive issue for the betterment of the society. Because see, I am one of the witnesses for the person who is suffering from the cleft lip, cleft palate, even post surgery also. One of my relative, very close relative, he was the patient of cleft lip, cleft palate. Actually, his age is almost 29, 30 years right now. He was operated in a very big hospital at his childhood. But since his childhood, he is literally suffering from so many issues, even in a small hole or small rent in his palate. It creates such a big, time for him, and he's suffering literally. He has already suffered. He has faced more than 2 or 3 surgeries. But literally, after seeing him, I am so much I have concern with the clay plate and clay palette, my every patient I am very much keen about the congenital anomaly scan from the best hands in Yavatmal. And if it is needed, even I am referring the patients to the higher center also, just to rule out the clay plate and clay palette. As such, every anomaly is disastrous to the patient, but this is not life-threatening, and that's why it is not causing any major harm to the life. But this clay palette can make the life miserable for that boy or girl, especially for a girl, because as everybody knows that at the time of the marriage, the things which are taken into consideration, and one of the major factor is her beauty. And in many patients, if the surgery is not good, or if that clip is a little bit more wider, then she can face the problems. And thank you very much. And that is the importance of this congenital anomaly scan in every baby. And I'm happy that my very good friend, Dr. Mangesh Narwadkar, is touching to a subject which is very important in the diagnosis of the cleft lip. And I'm happy, and I'm waiting for another speaker, Dr. Neeta, how the things are corrected after the delivery of such baby. So thank you very much, Rashmi, for a wonderful subject. Thank you very much, everybody who are having direct concern with this program. Thank you, Renu Madam. Thank you, Science Integra, Bajaj Finance, everybody. And I'm looking forward for the feast on this very important subject. Thank you very much.
Thank you, Girishda, for all the kind words. Thank you very much for your presence. Would like to hear more from you on this same subject. Moving towards our scientific section, we have our zonal coordinator, Dr. Mangesh Narwadkar sir, as the first speaker. I would like to introduce sir to the house. Sir is consultant at Gargi Hospital at Nanded, and he is FIGO 2006 International Fellow on Maternal Health with diploma in endoscopy, and he was, as we all know, organizing secretary of EMOX 2012. At present, he is the zonal coordinator of EMOX, and he has been in Urogynecological Committee Chairperson FOXY 2014 to 2016. I would like to welcome you to the platform, sir, and we would like to hear from you.
Good evening, everybody. At the outset, I would like to thank the EMOX President, Dr. Kiran Kurtakoti, and Dr. Bipin Pandit sir for this wonderful initiative to involve all the office bearers in this kind of interactive CMEs. And I would like to thank Dr. Mane sir for to be on this CME as a guest of honor. I also thank Dr. Kundkar, Dr. Kahar, and all the office bearer to arrange such a CME on a very neglected topic of cleft lip and palate. Honestly, before going through this, when Dr. Kahar called me regarding how to present on this topic, I said what I'm going to do on this. And then literally on a second day of after her call, I got a patient which has a cleft lip, the suspected lip. And she asked me to terminate the pregnancy. And then I really wondered how she can take such a decision only on a cleft lip. Then I got into the details, and then I'm very much sure after this presentation, everybody who is listening to this presentation will get some idea how to deal the patient once we diagnose or we suspect a patient is having cleft lip or a palate. Then what kind of investigation you should do as an obstetrician, and what are the outcomes that patient can expect, or how to counsel these parents about the future necessary surgeries or difficulties they will experience once the baby is in their hand. So the oral cleft is one of the most common craniofacial malformation of the newborn. It can occur as a cleft lip alone, or it can occur with a lip and palate simultaneously, or only cleft palate can occur alone. Then, because the embryology is different for a cleft, developing cleft lip or a cleft palate, then we should know if you know the embryology, then the management becomes easy. Or when you as an obstetrician, when can you expect a problem? Basically, the timing of the development of a cleft lip and the cleft palate is different. So we should know the embryology. We should know that what are the agents which leads to this development of this pathology, which are the genes responsible for this. And trouble never comes seldom alone. So we have to, once we diagnose a case of a cleft palate or a cleft lip, we should also screen for other anomalies, which is called as a syndromic approach. And once we suppose that patient opts for a termination of pregnancy, or a patient had a previous delivery with a cleft lip palate, then we as obstetrician should able to know what kind of having a second child with a same problem again. So that is called as recurrence risk. Generally, the cleft lip comes with a unilateral problem, which is the most commonest one. Bilateral, which is less common, but median is almost rare. The cleft lip is called incomplete when the only upper lip is affected, and it's called complete when the defect extends to the nose. Now, we as Asians or Indians, what is the incidence of, or what is the prevalence of a cleft lip palate in our region? According to the data from the Smile Train, almost 35,000 babies born with a cleft lip or a palate every year, which is a very significant one. And it does not, the race and ethnicity will influence the cleft lip prevalence, but the cleft palate will occur in every segment or races or ethnicities in a very similar fashion. So the only the prevalence will change from the perspective of a cleft lip. The male to female ratio for a cleft lip or with or without palate is 2:1. And for a cleft palate, the ratio is reverse, 1:2. And it has been found that the maternal age more than 35 is associated with the increased risk of oral clefts in offsprings across various populations. And nowadays, we are getting mothers of more than 35 years because of a recent change in demography. As I said, the phase development starts from a 4th week of a gestation, and it gets completed by the age of 13 weeks. So the critical period is in between 6 to 12 weeks of a gestation. And it develops from 3 processes, like it's a frontonasal process, maxillary process, or a mandibular process. And this frontonasal process, there is a development of a nasal placoid, which develops into the nasal pit, and that nasal pit has an inner border which is called as the median nasal process, which joins together, and that is called an intermaxillary process, and the lateral nasal process. And this intermaxillary process joins with a maxillary process, leads to development of an philtrum and formation of an upper lip. So what are the parts which has been formed within a frontonasal? Is forehead, external nose, nasal cavity, nasal septum, and a philtrum of the upper lip. maxillary, which is forms in a lateral part of an upper lip and upper part of a cheek, and maxillary process will form chin and lower lip. So this will give you the idea how the face develops from these all the processes. And if you know this an embryology, then why cleft palate occurs alone, or why it has been happens, so you can get the idea from these developmental process. And the palate develops within a frontonasal process and a maxillary process, but it develops at around period of 56 to 60 days, means it's almost 7 to 8 weeks. So sometimes you cannot able to isolate the cleft palate because it develops slightly later. So the lip gets fused, but the palate remains open. So if you understand this, then you can expect a cleft palate, why the cleft palate becomes alone. There are multiple reasons. There are environmental factors, there are genetic factors which leads to development of this oral clefts. And when there is a associated syndromes, it is called as syndromic or a syndromes, and it has been found that almost 30% of the cases of cleft lip with or without palate, they have some sort of a syndrome, but it is more in cases of cleft palate when it's occurred alone. And it is because of some complex gene-to-gene reaction or a gene environmental interaction which leads to development of this part. One of the commonest, we as obstetrician, we take care whenever a patient comes to us for an preconceptional advice. We start on a folic acid, and it has been found that suppose that the patient is on some anticonvulsant drugs like phenytoin or a sodium valproate or a carbamazepine or a topiramate, which lowers the levels of an folic acid in the body, then that may lead to development of cleft lip or a palate. Also, the cytotoxic drugs like methotrexate also decrease the folate level. We obstetrician use ondansetron very oftenly. Even I was using it, and then although it is a very controversial that it may or may not cause a cleft lip, but it is better to avoid the ondansetron during the first like 8 or 10 weeks of a gestation. Although we never use a diazepam nowadays, but it has been, although it is found in mice studies, but it's human, there was no clear-cut interaction, or there was no clear association seen. We hardly use diazepam nowadays. Though we use nitrofurantoins to treat an urinary tract infection, but the data is still limited to say. But it is always better to avoid these drugs. Very often we do get cases of hyperemesis gravidarum, which are not responding to routine medication, and sometimes we may have to start steroids in the form of prednisolone or some. Then there is a possibility that it may lead to. There is although it is not been supported by recent studies, but the Google will give you the data to the patients, and then probably it will create some sort of an knee-jerk reaction, or there is a friction while having a counseling. So it is better to avoid these drugs. How much is needed for a folic acid to prevent such a problem? It is only 0.4 milligram. It will prevent a neural tube defect also. But how long we should start? It has been data says that if you start 1 month prior to the conception, then it is okay. And a patient who had a history of a cleft lip or palate in their family, then you may advise to start 1 milligram. And by and large, we obstetrician give almost a dose of almost 5 milligram. So we are not doing any injustice in prescribing folic acid. But only problem is that whenever the patient get a conception without our prior consultation, or a patient has not started a folic acid prior, then probability there is a risk of having a cleft lip or a palate. There is a slight but insignificant increase in the risk of a congenital anomaly once the mother is having obesity, and that oral cleft is also there. amniotic bland sequence, which is not given any details about this, but it is another potential cause. And viral infection, radiation, or a poorly managed diabetes. So by and large, that whenever a patient comes to us, that we should maintain everything normal, or we should prescribe only that indicated drugs to patients, so that we will avoid problems in our pregnancy. So whenever a patient comes to you for planning a pregnancy, you can reduce the risk by either discontinuing the drug which has anti-seizure, or you can reduce the dose, or you can give a supplemental folic acid with a higher dose of folic acid. A smoking or alcoholic stopping of alcohol and smoking will definitely going to help, and we are prescribing folic acid very generously. As I said that whenever we see a cleft lip or a palate, then we should look for, is there any associated another anomalies, that is we called as syndromic cases. And this is because of either single gene variants or a copy number variants. Means whenever there is a mixing of chromosome of mother and father, there either the gene is missing, or there is an extra information or extra part of a gene is there, and that may lead to development of oral cleft. In the literature, almost more than 100 syndromes been described, but there are 30% of the cases will have associated syndromes when there is only cleft lip with or without palate. But only isolated cases of cleft palate will have almost 50% of the association of syndrome. So one of the commonest syndrome is Van der Waals syndrome, which is this happens in a range of 1 to 2% of the cases, and it is autosomal dominant. There are multiple syndromes as a Stickler syndrome, deletion of chromosome 22q11, orofacial digital syndrome, type 1, Treacher-Collins syndrome. But as an obstetrician point of view, once we diagnose what we should do, I will going to describe in a few further next slides. The prenatal diagnosis of cleft lip starts from around 11 weeks, but we will get the better clarity only around 13 or even after 13 weeks. So for that, second trimester ultrasound is the best for a lip or a palate assessment. It can be complete or a partial. And as median cleft lip is rare, but it is associated with holoprosencephaly. So by and large, if there is some anomaly, or there is some structural or brain abnormality associated with this, so that it will definitely get diagnosed with a kind of an anomaly scan we do in setups like fetal medicine. So if there are some associated anomalies, then the detection becomes easy. But if it comes isolated, only cleft lip or a palate, then the sensitivity drops down to only 50%. And we will never expect this is in a low risk population. So the only that approach should be, the radiologist approach has to be very diligent for detection of this kind of anomalies. Prenatal diagnosis of a cleft palate. As I said, it is very difficult to diagnose palate, only isolated palate, because it has a low detection rate. The literature says that it with 3D ultrasound and MRI will improve the detection, but even only thing that if you diagnose a cleft palate, and then all the jugglery will start, until you are not, if you're not able to diagnose, then why would you subject this patient for the 3D or of MRI to diagnose such a thing? So it's a radiologist's role is very important in this. But my concern is that, as I said, that the diagnosis starts after the diagnosis becomes evident only after a 13 weeks or a 14 weeks. And by and large, we as an obstetrician, we do sonography, generally that around 7 to 8 weeks is called as a dating scan, and then 11 to 13 is NT scan for within a double marker. And then generally, because nowadays, as the MTP limit has been increased to 24 weeks, we have we subject these patients for anomaly scan around 21 weeks. So now diagnose a cleft lip or a palate at age of gestational age of 21 and 22, that is going to be very difficult to explain. So now if you advise an early anomaly scan around 17, 18 weeks, then it is that patient had to have a 4 ultrasound, which cost is around 8.5 thousand to 10,000 for these 4 ultrasounds, and additional burden of double marker or a quadruple marker or a NIPT. And then the probably that people are not very keen on doing it. So, and they have a concern of that if they're going to have an ultrasound too very often, then there is still a concern, even though the ultrasound is being in the market for almost 60 years. And if the radiologist or a gynecologist or obstetrician is not very keen on, then there is a possibility of low detection. As I previously mentioned, the cost is around 10 to 15,000. And now, if you diagnose in a cleft lip or a palate, then we need to do some certain further investigation to rule out syndromes. And then these additional costs will give the burden to the patients, and it is very difficult to explain as an obstetrician to the relatives. And if you want to terminate a pregnancy, nowadays the last 5 years with the use of an fetal medicine practice, I face I'm from Nanded and I face these problems. People are not ready to accept any kind of an anomaly in their child. They want a very designer baby. Everything has to be normal. And even they want to terminate a pregnancy for a reason of a cleft lip also. But it is very painful to do, and to do a termination at around 22 weeks only for a cleft lip, and then legal issue do come into the picture. So if a radiologist or your scan suggests that there is a fetal facial cleft, so our job is to diagnose whether it is a paramedian, whether it is bilateral, or it's a midline. Midline is rare, paramedian is more often, and bilateral is again very less frequent. So if there is a cleft lip, then is it associated with any other abnormalities, or there are some anomalies, associated anomalies with it. So, as I said, the trouble seldom comes solo. So, whenever we find one anomaly, that it is our duty to find out if there are another anomalies are associated with not. So, by and large, central nervous system and a skeletal system, there are 33% chance that it has abnormalities of this system once there is a facial cleft is seen, and in tune of 24% the cardiovascular problems been expected. As I previously said, that it is 50% of the newborns with a cleft palate, 20% with a cleft lip and cleft palate, and 8% with a cleft lip are associated with an anomalies. In the second half of a pregnancy, there is impaired fetal swallowing may lead to an polyhydramnios, and this may lead to a preterm labor also. So there are ways you can diagnose cleft lip. Now, what is the role of an obstetrician like us to once radiologist gives us a diagnosis that there is some facial cleft? So by and large, we are doing double marker at around 11 to 13 weeks. But it has been found that almost 40 to 60% with cleft lip, with or without palate, have associated anomalies. So trisomy 13 was more in these patients. So we had to do either quadruple or NIPS. And we should offer a chorea sampling if it is diagnosed early, or amniocentesis if the pregnancy is beyond 16 weeks. And we had to do a chromosomal microarray, which takes around 13 to 15 days to get the proper report, and almost 16 to 20,000 rupees depending upon the city. And this, if there is a problem also, if there is the microarray results are normal, then we can ask the laboratory to perform some gene panels, like there are almost 12 dozens of clefting associated genes can be tested in proper manner. So it is very difficult for that couple to explain all these, and by and large, when we explain all these, then their probability of continuing a pregnancy becomes almost zero. So if there are associated anomalies, then the probability of chromosomal abnormalities is increased. So if you're not doing any chromosomal microarray in these patients, so if the pregnancy is being terminated, we can subject the products of conception for this chromosomal study, so that we can able to give the possibility of recurrence in a future pregnancy. So now, if the patient wants to continue a pregnancy, so we have to give them the idea that even though ultrasound diagnose on a cleft lip or palate or associated anomaly, there is risk of it may not give you the full idea regarding cognitive or a sensory deficit. So we need to have a genetic counseling for once we get the results of this and how to interpret these results. We have to refer them to neonatology. So what kind of a problem they will expect during immediate neonatal period, and how they plan for a future surgery. And lactation consultants or neonatology people will give them the idea about feeding and lactation. And as I previously said, that polyhydramnios with when it can occur in a patient with microagnesia and may lead to a preterm labor. So we may have to deal with the problems of preterm or preterm delivery or preterm problems also. Now, if the pregnancy is being terminated, or because of a syndromic syndrome associated syndromes, or a patient had a delivery with an cleft lip and palate, then the risk of recurrence risk in next pregnancy without any syndrome is in range of 2 to 5%, and it gets to 50% if the dominant disorder is being found with minimally affected parents. Oral cleft in the family history also increases the risk. So it is mandatory as an obstetrician. We should ask the history. Is there any family history of cleft in anybody's family? Once we know that, then we have to conduct thorough family history and do a physical examination. And there is always a risk for cleft palate compared to cleft lip and cleft palate. As I said, it's embryologically different origins of problem. And geneticists help, clinical geneticists help in detailed evaluation and testing will really help these parents to go about rather take a decision for a future pregnancy. Thank you. Thank you very much for patient listening.
Thank you, Dr. Mangesh, sir. That has been a very nice, elaborate, wonderful talk. You have covered very nicely the entire aspect, including embryology, the risk factors, what are the things to reduce the incidence of cleft lip, cleft palate, prenatal diagnosis and post-diagnostic evaluation, recurrence risk, and all those things. I would like to comment about prenatal diagnosis here. See, cleft lip can be diagnosed at around 13-14 weeks in a moderately built non-obese patient with advent of good machines, very good machines. You can at least suspect, or you can see directly the lips. But detection or diagnosis of cleft palate, isolated cleft palate, is challenging. So nowadays there is a equal to sign of uvula. It is seen at the level of oropharynx in coronal section. When there is fluid in oropharynx, you can see 2 lines of uvula. That is the most distal end of soft palate. If you can see it, you are ruling out straightway isolated cleft palate. That is a very simple sign, and with experience, it won't take more than 1 or 2 minutes. This should be used as a screening in each and every patient. It is especially very much useful when there is history of cleft lip or cleft palate, isolated cleft palate in the history or in siblings or in the family. And if you don't find this, you will equal to sign in this coronal section. You have to go directly visualization for the soft palate in mid-serratus section with slightly extended neck of the fetus with some fluid in oropharynx. That will give the direct visualization of soft palate. Complete entire soft palate can be seen in this section. So these two things can be kept in the mind when you are imaging the for cleft lip and cleft palate. Thank you. Thank you for wonderful talk, sir.
Dr. Konkar, I would like to ask you one thing that I'm a general obstetrician. I hardly have any inclination toward a fetal medicine. But the only problem is that what as an obstetrician I should do, how many scans I should do so that I will be able to pinpoint all the things. Should I do an NT scan or should I go for a quadruple, like 16-week scan with a quadruple? So which one, like my niece is in US and they directly calls her out at around 16 to 18 weeks, and then they do it only these two tests. So are we burdening the patient or are we doing extra? So which is the better approach for this?
You can't escape the 11 to 13 week 6-day scan. NT scan is must. There are number of things which you can give. It tells you more than 50 grade major chromosomal abnormalities, mere structural abnormalities can be diagnosed in that scan. You can suspect structural abnormalities. You can have aneuploidy screening. It is screening for preeclampsia, screening for preterm labor, screening for past in previous cesarean section cases. So it gives a lot of information. You cannot go directly, you can jump, don't jump directly on 16, 18 week scan on anomaly scan. You have to go for 12 to 13 week scan. It is very, very important.
So now the problem remains as the diagnosis. Now we are dealing with the problem of cleft lip and palate.
Yeah.
This will get diagnosed, and recently this is diagnosed at 21 weeks. So which is more troubling, that the patient is now complaining that the doctor didn't give me any idea about why they didn't give me early idea. So they should not, they do not understand the embryology, and so the problem becomes more worsening now.
Yeah. That is the problem of late diagnosis.
Okay, thank you very much.
Thank you for elaborate talk, sir.
After this wonderful talk, let's move on to the another session.
Suchira, can you tell us the attendance, today's attendance, please? Sorry for the disturbance.
Yes, ma'am. We are having 319 live users. And it's an amazing thing that all are watching our great show.
Thank you so much. It's a very respectable figure. 319 live viewers log in at present. Thank you so much. Jaya, please continue.
Yeah. So our next session, the topic is postnatal management of cleft lip and palate, and we have esteemed speaker Dr. Neeta Bhargava ma'am. With great honor, I would like to introduce her. She is MBBS DNB with an experience of 20 years. Presently, she is HOD and senior consultant pediatric and neonatology at Vivekananda Polyclinic and Institute of Medical Sciences, Lucknow. She is also National Nutritional Advisor for Smile Train India. She is PGDNB teacher in pediatrics and family medicine, BLS and PALS instructor, secretary, LAP intensive care chapter, and an author with various publications in index journals. I welcome you, ma'am, and we are eager to listen to you.
Thank you. Thank you, Dr. Rashmi, for nice introduction. So I'm sharing my slides. Can you see my slides?
Yes, ma'am.
Yes, ma'am.
Am I audible?
Yes, ma'am.
Okay. So good evening, everyone. It's my proud privilege to be a part of this wonderful webinar. And thanks to entire webinar team for giving me the opportunity to be a part of this webinar. And Dr. Mangesh has already covered the antenatal management of newborn babies with cleft. I will be covering the postnatal management of cleft babies. As we know, that orofacial cleft is a common congenital anomaly. Worldwide incidence is around 1:700. Cleft care begins from prenatal diagnosis to adulthood. Obstetrician and pediatrician are the first healthcare provider. Long-term cleft care requires a multidisciplinary cleft team that includes pediatricians, nutritionalist, plastic surgeon, speech therapist, otorhinolaryngologist, genetist, nurses, psychologist, and social workers. So multidisciplinary team approach is there for managing cleft babies. Thorough newborn examination is very, very important once the baby is born, because if cleft palate is undiagnosed, then it can lead to feeding difficulties and poor weight gain later on. So every effort should be made to visualize the palate during the initial newborn examination in the birth hospital to exclude the presence of cleft palate. An estimated 1 in 10 children born with cleft lip and palate, they die before their first birthday because of malnutrition. So we have to prevent this malnutrition. Something as simple as proper feeding instructions can make a world of difference over time. So we have to take care of nutrition part postnatally in cleft babies. Let's see the importance of initial 1000 days of life. That means 270 days in mother's womb and 730 days after the birth. That means 2 years till from birth to 2 years of age. This critical period is very, very important for the growth and development, because not only the physical growth occurs, brain grows maximally during this period. And if any nutritional insult is there during this period, can lead to devastating consequences. So we have to be very, very careful about the nutrition part in initial 1000 days of life. And for our cleft babies, these postnatal 2 years are very, very important, because normally lip repair surgery occurs between 3 months to 6 months, and cleft lip palate repair occurs between 6 months to 12 months. So we have to take care of nutrition part. If good nutrition is there, then timely surgery will be done and good surgical outcome will be there. So let's see how to maintain nutrition in cleft babies. What WHO guidelines says. According to IYCF guidelines, there should be initiation of breastfeeding within an hour of birth. And there should be exclusive breastfeeding for 6 months. Exclusive means no pre-lacteal should be given to the baby in the form of water, top milk, honey, bhuti, or etc. So only breast milk should be given till 6 months of age, and we should continue breastfeeding at least up to 2 years of age or beyond. And we have to introduce nutritionally adequate, safe complementary feeding from the age of from the 6 months onwards, along with the breastfeeding. And we have to give vitamin D and iron supplements to each and every baby. Vitamin D 400 international unit per day from birth to 1 year, and iron for 3 months from 4 months onwards. And we should ensure support to the mother from the family, community, and health facilities. So these are according to the infant and young child feeding guidelines. And there are many advantages of breast milk in mother as well as the baby. In mother, it is economical, convenient, time-saving. It promotes involution of uterus. It reduces risk of postpartum hemorrhage, postpartum depression, breast and ovarian cancer. And it has tremendous emotional benefits. It creates lifelong bond between the mother and the baby. It provides a sense of accomplishment in mother. Exclusive breastfeeding helps in spacing because of high prolactin level, and it accelerates recovery of pre-pregnancy weight. These are the advantages of breastfeeding in mother. But there are n number of advantages in babies, because this is a complete nutrition till 6 months of age. So this breast milk is nutritionally superior complete food. It promotes optimal growth of the baby. It has many immunological factors which protects the children against getting infection. And the colostrum is in fact the first vaccine, because it is rich in immunoglobulins and it protects the baby from infection. And this breast milk also reduces the risk of asthma, atopic conditions, type 1 diabetes, celiac disease, dental caries, sudden infant death syndrome, coronary artery disease, hypertension, and obesity in later adulthood. And it is associated with greater intelligence. Breastfed babies have higher IQ, 8 points higher IQ than other top milk babies due to high levels of arachidonic acid, DHA, lactose, and salicylic acid. And it provides warmth, security, and bonding. And most beautiful part is it stimulates all 5 sensory organ of the baby. There is a skin-to-skin contact, so there is tactile stimulation during breastfeeding. Baby smells the milk, so there is olfactory stimulation. Baby hears the tick-tock sound of mother's heartbeat, so there is auditory stimulation. And baby interacts while taking breastfeeding with the mother, so there is visual stimulation, and baby tastes the milk, so there is gustatory. So it stimulates all 5 sense organ. These are the advantages of breastfeeding in babies, but in our cleft babies, there are additional advantages of breastfeeding because these babies are very prone for ear infection. So breastfeeding protects against infection and lowers the risk of ear infection. And it helps strengthen the muscle around the face and mouth to promote better speech development. And as breast tissue is very much flexible, it helps in accommodating the oral cavity and sealing the cleft better than bottle nipple, because if small cleft is there in the cleft lip, then breast tissue seals that cleft, and sometimes direct breastfeeding is possible. An infant has more control over positioning and milk flow while taking breastfeeding. As breast milk is a natural substance, it is less irritating even if regurgitate out the nose. We should encourage all mothers to put the baby to breast for 5 minutes on each side, even if breastfeeding is not possible, because licking of nipple itself is a stimulus. So breastfeeding provides the closeness and interaction required by infant. They can suckle for comfort, not just for food. So these are the added advantage of breastfeeding in our cleft babies. But there are many challenges of direct breastfeeding in cleft babies. Let's see what is the mechanism of breastfeeding. Now in this picture, you can see when the baby takes full nipple or areola inside the mouth, baby forms a seal around the areola with the lip, and intact palate goes up and closes the nasopharynx. So there is vacuum created inside, or negative pressure created inside the oral cavity. And because of this negative pressure or vacuum, baby draws the milk from the milk glands. So this is the normal mechanism of breastfeeding. And but what happens in our cleft babies? Because of the cleft, that seal is not formed, and palate is not intact, so it will not close the nasopharynx. So negative pressure is not created, no vacuum, so no seal, no vacuum, and baby is unable to draw milk from the mammary gland. So this happens with our cleft babies. So there is failure of direct breastfeeding. They have difficulty in maintaining a good seal. There is non-rhythmic suck. There is aerophagia. They take lots of air inside the stomach. There is gagging and choking, milk leaking out of the nose. An infant may tire more easily and not feed long enough to get the hind milk, because hind milk contains lots of fat. And so there will be lesser weight gain in these babies. And mothers may not have sufficient milk or the confidence. So these are the factors. These are the challenges we are there with the cleft babies. Now we'll see what are the factors responsible for increase or decrease milk production, because we have to counsel mother about the breast milk, advantages of breast milk, and at any cost we have to save the breast milk. So we should counsel mother regarding the factors responsible for increase or decrease production of milk. Let's see what is letdown reflux. When the baby takes baby sucks the nipple, or if mother is emptying her breast, that positive stimulus goes to posterior pituitary in the brain, and prolactin and oxytocin hormones are released. This prolactin is responsible for milk production, and oxytocin is responsible for milk letdown reflux. So lactation occurs. So this is a normal letdown reflux. But when the baby is not sucking the breast properly, or if mother is not emptying her breast, then negative stimulus goes to the posterior pituitary, and these hormones are not released, and so slowly lactation process or lactation suppression sets in. So we have to prevent this lactation suppression in cleft babies. So the factors responsible for increased milk production, as we have discussed, stimulation by frequent sucking, this is the main stimulus. Then support and encouragement from partner and family, and sharing the household responsibilities. This is very, very important because mother should be in relaxed condition while feeding the baby. Drinking plenty of water. Water is the best galactogore. Feeding on demand. Watch for infants' cues. Feeding at least every 1 to 3 hourly, because if every 1 to 3 hourly mother is feeding the baby, breasts are emptying, then again there is positive stimulus goes to brain and milk lactation will continue. And warm compresses on breast before feeding. Then massaging breast before and during feeding. Then manual expression of milk. Early initiation of breastfeeding. As WHO guidelines also says, कि immediately after the birth of the baby, immediately put the baby over mother's chest, or breast crawl should be adopted, and there will be skin to skin contact and initiation of breastfeeding. Then expressing milk within first few hours of birth. Then relaxation technique, massaging will increase oxytocin level in the blood, and lactation will continue. And skin to skin contact. These are the factors which are responsible for increase in milk production in the mother. Then the factors responsible for decreased production are sucking difficulties, as we face in our cleft babies, incomplete emptying of the breast. Even if mother is not direct breastfeeding the baby, then she can empty her breast. And if she is not emptying, again there will be negative stimulus goes to brain. Then if mother is in stress, then also it's very inhibitory for lactation. Hormonal or endocrine problems in mother, using birth control pills by mother, taking certain medications or herbs if she's not feeding at night, because prolactin levels are very high during night time. Then scheduled feeding, top milk supplementation in the baby along with the breastfeeding, or if mother or baby, if there is dehydration in them. So these are the factors responsible for increase and decrease milk production. So it's a use it or lose it process. When breasts are full, there will be slower milk production. And when breasts are empty, there is faster milk production. So we should counsel mother regarding emptying of breast. Even if baby is not able to take direct breastfeeding, she should empty her breast frequently. And she can store that breast milk and give it to baby with katori spoon or palate spoon or nifty cup. So when the isolated small cleft is there, then breastfeeding is possible. We should encourage mother to go for direct breastfeeding and help baby to suckle in a good position, and taking enough of breast may close over the cleft so that the baby can suckle well, because breast tissue is very much flexible. So small cleft, this breast tissue sometimes seals that cleft, or mother can seal the small cleft with her finger, and breastfeeding is possible because of seal. In case of unilateral cleft lip, we can position the nipple away from the cleft, but sucking is difficult if bilateral cleft is there or if palate is associated with this. So there are many positions of breastfeeding. If mother and baby both are comfortable with any position of breastfeeding, or if direct breastfeeding is possible with any position, then they should continue with that position. But there are few positions in which breastfeeding is it is beneficial for these cleft babies. So one of the important position is dancer hold position. In this picture, you can see how mother is holding the baby, and she's applying gentle pressure to the masseter muscle with the thumb and index finger, and she's stabilizing the jaw, and she's pulling the jaw slightly forward. And this may allow the infant to better grasp the breast and form a seal. So this is a very important position of breastfeeding in cleft babies. And her another hand is free to support the infant's neck and shoulder. So this is the one major position in cleft babies for direct breastfeeding. Another position is modified cradle hold position. In all three pictures, you can see the modified cradle hold position, how she is holding the baby and giving feeds. And another position is rugby hold position. This is also known as footballer's position. And now you can see the mother is holding the head of the baby like a football. And in this position, she can feed the twin babies also. So these are three important positions which are beneficial for babies with cleft for direct breastfeeding. Now, there is a problem of aerophagia in these babies. They take lots of air inside. So burping is very, very important after the feeding. So these are 3 positions in which mother pets the chest of the baby. In this position, we can do burping. Now, normally mothers complain there is inadequacy of breast milk. So how to counsel mother regarding adequacy of breast milk? So first most important thing is adequate weight gain. So periodic growth monitoring, periodic anthropometric parameters monitoring is very, very important. So if the baby is gaining weight adequately, that means breast milk is adequate. If the baby passes frequent urine 6 or more times in a day, that means breast milk is adequate. If baby sleeps after taking feed for 2 to 3 hours or becomes calm and playful, then also it indicates adequate breast milk or her baby's tummy is full. And when the mother feels the difference in the breast before and after the feeding, then also it indicates breast milk is there. And there will be drip milk while feeding the baby. From another breast, there is dripping of the milk. That also shows adequacy of breast milk and frequent passage of stool. So these are the pointers which show adequacy of breast milk. So we have to counsel mother regarding this. Then what happens if direct breastfeeding is not possible in spite of all these measures? Then we should advise mother to express the breast milk either manually or by breast pump. So there is a method of manual expression of breast milk. So this is 6 and 12 o'clock position, and this is 3 and 6 o'clock position. She should do massaging or hot fomentation before expressing the breast milk, and she can put the baby on the breast. Even if baby is not taking direct breastfeeding, licking itself is a very good stimulus. So after that, mother can manually express the breast milk. The method is first is press. She will press the breast towards the chest, and then slowly she will compress the milk glands and then release. So milk will come out, and she will repeat the same procedure. And when the milk is not coming out, she can change the position from 12 to 6 to 3 to 9 position. So repeatedly she can do, and she will express the milk. In this picture also, you can see she's massaging, then expressing the milk and giving this expressed breast milk with a katori spoon. We should be careful while the hygiene part also. Before hand hygiene should be properly maintained before expressing the milk, and milk should be stored in on boiled container and or sterilized container with closed lid. So how to store this expressed breast milk while this is another method for expressing the milk by breast pump, and manual breast pump are also there and electric breast pump are also there. But manual expression is always better because it stimulates breast milk production to ensure continuous milk supply, expresses colostrum also, can relieve engorgement or blocked duct also, free of cost, no need to sterilize pump, no electricity needed, does not cause discomfort, and skin-to-skin contact is very stimulating. So we should advise mother about expression of breast milk. Then how to store the expressed breast milk? We have to do counseling regarding storage. At room temperature, she can store the expressed breast milk or EBM in a clean container with closed lid at 4 hours in room temperature, 24 hours in refrigerator, and at 6 months in deep freezer. So, but after taking out the milk from the refrigerator, she should keep that bowl in lukewarm water for maintenance of temperature, and only after she can give the feed to the baby. Now, after expressing the breast milk, she can give that EBM through palate spoon or by nifty cup, or through simple spoon also she can feed the baby. But this palate spoon is very good for cleft babies also. From the angle of the mouth, she can slowly pour the milk. Do not flush the pharynx with too much of milk. So slowly and slowly with head should be at 45-degree angle. She can feed the baby. Here also you can see the mother is feeding the baby with palate spoon and nifty cup. And we have to give very small amount of liquid by holding the head at 45 degree and do not flush the pharynx because it will cause choking and aspiration. So in this picture also you can see she is not maintaining the hygiene because she is dipping her finger. So we should counsel mother regarding hygiene. Baby is crying and if she's feeding the baby, this is not okay. Too much extension of the neck, too much flexion of the neck. So these are not okay. So always feed the baby in proper position with 45-degree head up. So what are the breast milk alternative? In spite of all these measures, by the time they reach us, there is already lactation suppression sets in. So how to counsel mother if breast milk is not there? Because we have to, at any cost, we have to maintain the nutrition of the baby. So first we recommend direct breastfeeding. If it is not possible, then express breast milk or mother's own milk with katori spoon. If it is not there, then pasteurized human donor milk or human milk banks are also there. So from there we can give donor milk. Then commercial infant formula milk, but we have to tell about the hygiene and how to maintain that, how to make that infant formula. And lastly, animal milk comes. So animal milk, normally cow milk, we start after 1 year of age. So a few lines about oral hygiene. Milk enters the nose during feeding in a cleft babies. Breast milk does not irritate the delicate nasopharyngeal tissue because it's a natural substance, but formula milk leaves deposits, resulting in a stifling baby. So always give boiled cooled water after feeding the baby, 2 to 3 spoons to clear the nasal passage. And these infants are also vulnerable to tooth decay. So good oral hygiene, cutting down on sugar, and regular visits to pedodontist is important. Now, according to American Academy of Pediatrics, they recommend that newborn infants with cleft lip and palate be seen for early newborn follow-up by their primary care pediatrician and evaluated by a cleft craniofacial specialist or team as soon as possible after discharge from the birth hospitalization, ideally within 1 week of discharge. So we have to check all newborn baby within 1 week, and it is a multidisciplinary approach. So assess weight, jaundice, feeding, newborn health, and maternal and family well-being of each and every child, and hearing assessment for each and every baby. Just few lines about the complementary feeding, because till 6 months, breast milk is the complete food. But after 6 months, breast milk is not sufficient to fulfill the demand of the baby. So we have to start complementary feeding after 6 months onwards, along with the breastfeeding. And breastfeeding will continue till 2 years or beyond. So this is a food group pyramid. Here you can see the different food groups: cereals, pulses, green vegetables, fruits, then milk and milk products, then animal product, and fats and oil. So the principle is, this is a complete diet if all food components are there in the diet, but it becomes balanced diet when they are in adequate amount. So we have to introduce all food items to the baby one by one, and slowly one by one in increasing quantity, and to start with liquid consistency and slowly semi-solid consistency as age advances. And we have to make the food energy dense by adding sugar, oil, ghee, butter, or jaggery in it. And vitamin D and iron supplements, as we have discussed earlier. Maintain hygiene while making the food and while giving the food also. So this is the principle of complementary feeding. And for sitters, pureed food, crawlers, mashed food, and when the baby starts standing, then minced food. So this is the consistency or texture we keep in complementary feeding. So this is all about nutrition part of the baby till 6 months and beyond that also. But at the end, counseling is, we must know that counseling is mainstay, and we should start doing counseling of parents from antenatal period onwards once the cleft is detected. These young parents, they are in very much anxiety and helplessness situation because cleft is revealed. So we have to counsel parents that simple cleft lip and cleft palate is not an indication for termination of pregnancy unless until it is associated with multiple congenital anomalies. And this is easily correctable with surgery. But only thing is we have to take care of nutrition part of the baby before surgery so that good surgical outcome will be there. And we have to prepare the parents mentally and provide them moral support also during antenatal period onwards. And we should inform the parents about the anticipated challenges and difficulties with breastfeeding in cleft babies, so that we should prepare the mother about these difficulties and how to maintain lactation even if direct breastfeeding is not possible. So at any cost, we have to save breast milk. So if we start counseling from antenatal period onwards, then only we can save the breast milk. Otherwise, by the time they reach to us, it's very late and already they come with lactation suppression. So we have to advise mother regarding methods of different direct breastfeeding, prevention of lactation suppression, how to feed baby with spoon or nifty cup. Periodic growth monitoring is very, very important to prevent malnutrition, timely introduction of complementary feed, how to give post-surgical diet and care. Because if good nutrition is there in the baby, good weight is there, then timely surgery will be there and good surgical outcome will be there, and we can return the smile of the baby as well as the family member. Thank you.
It was excellent and elaborative talk, ma'am. You covered everything, including benefits of breastfeeding, mechanism, challenges the mothers or the parents face, the positions and everything, including counseling, which is must. So thank you so much, ma'am, for such a nice deliberation.
This question is from Dr. Kamlesh Singh. 3 main body types are endomorph, mesomorph, ectomorph. Whether it should be considered while drafting the nutrition plan in these babies?
Actually, this body shapes and these come later on. In newborn babies, we cannot assess with ectomorph or mesomorph. So nutrition part is almost same for all babies. So we have to give only principle is to save breast milk because it will provide all nutrients to the baby, whatever is the body composition or body shape. So for newborn baby till 2 years of age, everything is same. But in adolescent age, yes, it depends because feeding habits and lifestyles are changing. So for all type of physical nutrition part is same. We have to start complementary feeding in time from 6 months onwards. We have to include all food groups, all nutrients in balanced amount in the diet. If you are giving feeding with the milk, or milk is the main diet, then again they come with severe iron deficiency anemia, and brain growth also suffers.
Thank you, ma'am. Are there any more questions, Suchira?
No, sir.
Thank you.
Anything you want to add, Dr. Mangesh?
No, nothing. It was a wonderful. That I basically I never ever got the opportunity to go into too much of details of a cleft lip or a palate. So thank you for this opportunity. And I really wonder this has to be a part of management. And basically my practice is going to improve. And I think after this presentation, people will look for these problems and manage accordingly.
It is going to be very much useful for all obstetricians and all for common public also, because this is our 9th series amongst with Smile Train. This is our 9th series of the webinar, and in each and every webinar we are getting so many new things to listen from eminent speakers like you. So this is going to be so beneficial for all of us.
Thank you, Dr. Sujit.
So
sure. I hope we'll wind up now.
Yeah, we'll go to vote of thanks. I am very delighted to deliver vote of thanks on this occasion. Special thanks to our speakers today, Dr. Mangesh sir and Dr. Nita ma'am, for enlightening us with their great knowledge. Many thanks to AMOG's President Dr. Kiran sir and Dr. Secretary Dr. Pandit sir for constant source of inspiration with help for this series. Many thanks, Smile Train, Dr. Renu Mehta ma'am, for continued association. Great thanks to Smile Science Integra. Suchira is having so much efforts to make this successful, and no program is successful without the involvement of delegates. So great thanks to all the delegates who have logged in for this program. Thank you so much.
Thank you.
Thank you so much, sir. Thank you.
Thank you, everyone.
Thank you, ma'am. Thank you.